This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here at the Institute.
And I'm Dr. Alara, research fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in early 2026. It's a systematic review and meta-analysis focused on the efficacy of combining ICG videoangiography, or ICG-VA, with Flow 800 software in the surgical management of intracranial aneurysms.
This is a timely one, Alora. For the residents listening, we've used ICG-VA for years. It's that moment in the OR where we turn off the lights, inject the dye, and watch the vessels glow. It's great for seeing if a vessel is patent, but it's always been purely qualitative. You're looking at a screen and making a subjective call. That looks bright enough, or I think that branch is filling.
Exactly. And that, I think, is where Flow 800 comes in. This paper, led by Turpo Pequeña and colleagues, really dives into how adding that semi-quantitative layer changes our intraoperative decision-making. They looked at 12 studies involving 344 aneurysms.
Before we get into the meat of the meta-analysis, let's quickly refresh everyone on what Flow 800 actually does. Unlike standard ICG-VA, which is just a video loop, Flow 800 processes those infrared signals to create a color-coded map. It looks at the time to peak intensity and the transit time of the dye.
Right. It turns a black and white video into a hemodynamic heat map. Red usually represents fast arterial flow, and blue represents slower venous return. In this meta-analysis, they were looking for 4 specific outcomes: misclipping, aneurysmal remnants, vascular stenosis or occlusion, and most importantly for the surgeon, clip repositioning.
Let's talk numbers. What did the pooled data show for misclipping?
The pooled intraoperative detection rate for misclipping was 9.36%. That's nearly 1 in 10 cases where the combination of ICG and Flow 800 caught an issue that needed addressing. For actual aneurysmal remnants, the rate was 6.55%.
That 9% for misclipping is significant. In the old days, if you didn't have intraoperative DSA, digital subtraction angiography, you might not realize you'd compromised a perforator or left a dog ear on the neck until the post-op scan. By then, the patient is in the ICU and you're looking at a much more difficult return to the OR.
And the study showed that vessel stenosis or occlusion was detected in 6.9% of cases. The authors noted that Flow 800 is particularly good here because it can show a delay in flow in a branch that might still look bright on standard ICG, but is actually being pinched by the clip blade.
That's the semi-quantitative advantage. I've had cases where the vessel looks pink and healthy, but the Flow 800 map shows a clear shift from red to yellow or green, indicating a drop in perfusion pressure. That's your signal to back off, reposition the clip, and save the patient from an ischemic stroke. Speaking of which, what was the rate of clip repositioning in this study?
The rate of clip repositioning was 8.13%. So in roughly 8% of these 344 aneurysms, the surgeon changed their construct based on what the ICG-VA and Flow 800 told them. That's a direct impact on the surgical result.
Now, Ilara, as a researcher, I'm sure you looked at the meta-regression in the subgroups. Was there anything that stood out regarding patient demographics or study design?
Definitely. One of the most interesting findings was that older patient age was a significant predictor for both remnant detection and the need for clip repositioning. The p-value for age and remnants was 0.0247, and for clip repositioning, it was 0.0073.
That makes perfect clinical sense. In older patients, we're dealing with more atherosclerotic disease, calcified aneurysm necks, and less pliable vessel walls. When you apply a clip to a calcified neck, it doesn't always zip shut perfectly. It can slip, or the calcium can prevent the blades from meeting, leaving a small gap. It's reassuring to see the data back up what we feel in our hands in the OR.
Another point the authors made was the difference between retrospective and prospective studies. The retrospective studies actually showed higher detection rates,
which usually suggests a bit of selection bias, or perhaps that we only tend to publish our saves when we're looking back at the data. But even with that, the prospective data still supports the utility. Was there a comparison to the gold standard intraoperative DSA?
That's the caveat. The authors noted that while ICG-VA and Flow 800 are excellent, they shouldn't necessarily replace DSA, especially in complex or giant aneurysms. ICG is a line-of-sight technology. If a remnant is hidden behind the parent vessel or the clip itself, the infrared camera won't see it. DSA is still the only way to get a true 360-degree look at the reconstruction.
Exactly. I tell my residents, ICG tells you about the vessels you can see, DSA tells you about the vessels you can't. But bringing the C-arm in for a DSA is time-consuming, requires a scrub tech, and carries a small risk of its own. ICG-VA with Flow 800 is essentially free once you have the microscope software.
The paper actually graded the certainty of the evidence. They gave moderate certainty for misclipping and clip repositioning, but low certainty for remnants and stenosis. This was mainly due to the heterogeneity of how different centers define a remnant and the lack of a universal threshold for what constitutes a significant flow delay on Flow 800.
That's a great point for the residents. We don't have a magic number yet. If the transit time is delayed by half a second, is that a problem? Or do we wait for a 2.0-second delay? We're still in the era of clinical judgment supplemented by this data.
The authors concluded that this combination is a powerful complementary tool. It enhances the detection of flow disturbances that are invisible to the naked eye and even to standard ICG.
So if you're a junior attending setting up your practice, what's the takeaway here?
I'd say use it every time. It's non-invasive, fast, and according to this meta-analysis, it's going to catch a potentially devastating misclipping in nearly 10% of your cases. Even if you think the clip is perfect, the Flow 800 might tell you a different story about the hemodynamics in the distal branches.
And for the medical students listening, it's a great example of how software is augmenting traditional surgery. We aren't just looking through glass anymore. We're looking through a digital interface that's processing data in real time.
It also highlights the need for more prospective multi-center trials. The authors were very clear that while the 2026 data is strong, we need better validation against angiographic standards to really define those red flags on the flow map.
Well, this has been a great breakdown, Alara. The paper again is Efficacy of Intraoperative Indocyanine Green Videoangiography and Flow 800 in the Surgical Management of Intracranial Aneurysms, published in Acta Neurochirurgica.
It's a must-read for anyone heading into a vascular fellowship.
Absolutely. Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the OR.
Until next time.